proceedings now via Zoom.
And we have to every now and then link up with various parts of the world to share experiences and to find out some more, get more lessons and find out some more about the disease. Just an hour or so ago, I had the privilege to represent President Cyril Ramaphosa in a meeting which was called the Solidarity Call to Action, which was hosted by the President of Costa Rica in conjunction with WHO. Here, with over 200 participants coming from all over the world, and the real issue is about ensuring that there's equity in the access of the information technology platforms, access to new technologies in vaccine and research, in diagnostics and in therapeutics that are available. And the whole world is clamoring for equity on this matter, effectively saying that this is a new issue, it's a new disease, and therefore a lot of treatment is not well established, and therefore as soon as it becomes available, it needs to be shared as a common property for all the public and all the different nations of the world with equal access to avoid any form of resource nationalism, and also a situation where the more wealthier countries are able to access everything to the disadvantage of the poorer countries. It's important as well that we have been in continuous contact with the WHO, and we have really respected the support and the guidance and leadership of the Director General, Dr. Tedros Ghebreyesus, who leads WHO, as well as our regional director in the Afro region, Dr. Matshidiso Moeti, and we're working very closely together with the WHO in our country, represented by our country representative, Dr. Owen Kalua, who is also working very closely with us as part of the health family. At some point, we will obviously request that Dr. Kalua, on behalf of WHO, make some comments in terms of their observation in the way that we are dealing with issues in South Africa. But it's also then important to say that with the various players that we work with, we want to pay tribute to the President for his leadership, as well as the members of Cabinet and the National Command Council on coronavirus for the guidance and all the work that they've done. We also pay tribute to all the health specialists, the experts, the researchers of various descriptions that work with us, advise us, and those clinicians in the forefront who are dealing with the infection on the day-to-day basis, together with the whole group of health workers, nurses, and other professions on the ground, community health workers, and all who are on a day-to-day basis involved in the fight against coronavirus, and are doing a wonderful job, sometimes at the risk to themselves. We do accept the role that they've played as being very important, and also they are actually in the forefront in the fight against this COVID-19. We do also wish to convey our condolences to the families and friends and those relatives of those members of staff or health workers who have actually lost their lives. In our current count today, we have about 14 of the health workers who are recorded to have passed during this period. And therefore, we can see that the numbers of those both in the health and other frontline services is indicating that more and more of our health workers are affected by the infection. There's been requests for various forms of information. In particular, we had a whole last week we had a whole day seminar where we were to share the information on the various modules, models, and various forecasts that have been put out there. And we found that this session was very, very helpful, and we really want to thank all those who participated, both the panelists and modelers, as well as those from the public who really raised a lot of debate around these matters. It actually improved the whole issue around the modeling. We have also been asked to release any additional information around the demographics of the infection. In this case, I must also upfront say some of the information is not available in the sense that it was never collected as such. So there were questions about the racial profile of the people who are both patients and those who have demised. We will then be doing some work to try and get as much of that information, because the information was not structured in that way as we're receiving it and as we're collecting it. It's important also to say that insofar as the COVID-19 is concerned, at this point, we actually don't see a distinction between most of the challenges that we face, which are affecting the majority of the South Africans, particularly amongst the Black community. And therefore, we do understand that a large number of the people who are both patients and those who would have succumbed from the infection are largely amongst the majority of the Black people in this country. The NICD will make some comment about some of the issues that get involved. So quite often, there's a lot of background housekeeping work that has to be done in reconciling as well as harmonizing the data at the back office. So sometimes when the questions are asked about why there are delays and so on, we never really explain every day what the challenges are, but a lot of it is administrative issues. We've spoken about backlogs of unallocated tests, and these were really a historical issue that arose in the past when we had a lot of foreigners who didn't have local addresses, and in some instances where the administration did not give us the correct details at the time. It took a long time to deal with, but those were problems that was part of the teething problem. The numbers still exist today because it's really to be kept on record as a matter of accuracy of our data. In addition, we have also had some of the people asking us a question about the data. If people have recovered, why do we keep the numbers? Why don't the numbers go down? In fact, there's a standard way of how the coronavirus records or COVID-19 records have been kept throughout the whole world. For standardization purposes, it is important to keep the total number, even if people would fall in the category of what we call resolved cases, which involves those who would have either recovered or those who would have demised, which we call closed cases. And then the active cases would be the difference between the total and those which we call resolved cases. This is a standard way of how this matter gets dealt with. We have felt it's important to talk about what the president has announced to the nation, what we call the differentiated approach to the COVID-19. And of today, we will actually have the pleasure of listening to some of the of our advisors. Professor Abdul Karim will also make a presentation, and then we'll also have some of the specialists in the laboratory services and some also in the health products regulatory authority will also just give us a sense of some of the work that's being done behind the scene to and ensure that our response on fighting COVID-19 is a strong response. We've also heard from various ministers who have indicated various issues, in particular, Minister of Culture who has indicated some of the regulations in terms of what is being dealt with now. I think it's important to say at this point that South Africa is in a bit of a unique situation. We are not like what happened in China, where we actually saw the lockdown imposed, and then when the infection was going up, and then the lockdown was kept in place until the infection rate was starting to go down. In our case, we're dealing with a much more complex situation because our infection arose from imported cases. We needed to impose a lockdown immediately to reduce the spread of the infection. But the infection is still going up, but now there are other considerations to take into account. The issues of hunger, social distress, the issues of income challenges, lots of small businesses and people who are employed and some who are earning casual, doing casual labor, who need daily incomes. All of these issues are very serious among South Africans, and therefore it becomes important to be able to say that whilst we want to make sure that we the infection, We also don't want people to be having a problem that they no longer can survive. And so we're trying to balance this. And so the president has called it the risk-adjusted approach, which is a way to try and ease the restriction, particularly because our experts have indicated that we've got the maximum benefit from the lockdown. So continuation of the lockdown in the way it was imposed is no longer sustainable. And so what we need to do is to accept the reality now. The reality is the COVID-19 as a disease is going to be with us for a year or two or more. And therefore, we need to begin to adjust to a new reality of how we're going to live through distancing and ensuring that everyone wears a mask when they leave their home, that they wash their hands and ensure hand sanitization, and also make sure that there is distancing. Every sector of society, every individual, every South African has to understand that that's a new way of life. So as we go about trying to make sure that we get our income, as we get our social life together, there are things that are not going to be possible to do, but it's not locked down the country forever. And we do understand that this debate has really been very strong in the country, but we also want to say that we cannot be in a position to keep the lockdown in the way that it was. And in some instances, we've seen people are agitating for their own sectors to be opened, but are very opposed to other sectors to be open. So because we have a meeting, we're going to take lessons from the public, we'll take lessons from our own researchers and try and do the best for the country. So we have therefore taken the, excuse me, we have taken the approach, excuse me, the approach of what is called the differentiated approach. Now, we have categorized firstly, it's based on every part of the country going to level 3 as announced by the president. And then we have differentiated into 3 kind of categories of the level of risk of transmission. The one category is what we call low transmission. We have announced the list of those particular districts where the major part of the country is actually what we could classify as low transmission area. And we have therefore said there's a different approach in those areas as we adjust to normality. Then the other area is the area that we call the high transmission area, which is called the hotspots. Those areas will also have interventions I'll go into in a few minutes. And then the other area will be areas where, despite all these efforts to contain the spread of the infection, then the situation is getting completely out of control. So if we approach it from that understanding, we need to understand that for every one of these situations, it means we must make sure that everybody focuses on the new approach of hand washing, masks for everybody, including cloth masks, as well as ensure that if there's some protection for the nose and mouth, as well as ensure that we emphasize on distancing. So these are the issues that will have to be dealt with. That have to be dealt with as we go back to school. There are lots of concerns about that. We'll talk about some of those issues, but in the process, we have asked that there must be screening before people walk in, so that you can pick up those who have got symptoms. That means those who have got symptoms of flu should really rather stay at home and report those, and therefore seek treatment for those rather than going to mix with some of their colleagues. But schools, in the mines, in the manufacturing factories, in the retail and in the churches and so on, here we're dealing with distancing and masks and so on. In the churches, the real issue is to actually ensure that there's distancing and the change in the approach of how the day-to-day church activities are, in a way that makes the churches to be in the forefront of teaching their own congregants how to avoid the infection. We understand there's a lot of challenges in this area in terms of the debates with a number of people raising issues. But where we are focusing then is that on the low transmission areas, we have said that there has to be vigilance, and we need to try and continue to ensure distancing, but also reduce the number of infections and be on the lookout for those. In the hotspots, we've also set up units of health experts to deal with those issues, those particular areas, and ensure that people are identified and they are taken for isolation and there's treatment given, and that all of that we ensure that we reduce the rate of spread of the infection. If all of those don't work out, there is still a possibility then that there will be stronger restrictions which are similar to the lockdown that we had much earlier. We will therefore deal with each area as the situation arises. What is important is that we are now advocating for behavioral change. To defeat COVID-19 is a social issue. It's not just what the doctors and the nurses will do. It's what society will do. It's what individuals will do. And therefore, we're focusing now on everything being organized at district level. The president has also indicated that he's going to deploy all the ministers into the various districts to go and give support. And so we'll be working very closely together with everyone at that kind of level. We will then talk about some of the issues about the pattern of the infection. We've noticed, for example, that in the past 2 weeks, we've actually 50% of the deaths that we've seen have actually emerged in the past 2 weeks. And the numbers that have also increased in the past 2 weeks have almost been, very close to almost half of the numbers that we're dealing with in terms of the total number of positive cases. So those kinds of patterns, Professor Abdul Karim will talk a little bit about. There are other issues that we'll comment about. There are fog tunnels where people are getting sprayed, and we've actually asked our Ministerial Committee to advise the public on these matters, and that will be dealt with as well. There are other issues that I've indicated in terms of the totals of tests that have been done, some of the challenges with the backlogs, which are a reality. In a way, we've actually increased our testing so high, but because we've also gone to test 13 million, to screen 13 million community members, we are now seeing that the global shortages are beginning to hit us, but nevertheless, we will not be discouraged by that. We will continue to do our best to contain the infection. So the SAHPRA will deal with the issues that relate to the approval of some of the diagnostic kits, and there has been lots of debate in the public. Would like you to ask questions so we can understand where we stand with all of that. In total, we've done over 655,000 tests, and we believe that's a very huge number, but at the same time, we believe a lot more still needs to be done. Maybe later on, we will talk about the situation a bit more detailed around the Western Cape, because it certainly emerges the epicenter with 65% of the tests being in that area, yet they contribute about 23% of the tests that have been done. So in fact, the highest number of tests are coming from Gauteng, not from Western Cape. And so Gauteng has been doing the tests in the same way, and they were leading in terms of the numbers of positive cases, but then the numbers increased. The number of infected people increased in the Western Cape. There's gone up. We also identified the clusters which were the source of these infections, and our approach to Western Cape is that we now have a team that's gone there to reinforce Western Cape. There's good cooperation, working well together. The Cuban specialists are already in Western Cape, as they are in the rest of all the provinces. So there is good work that we're doing to try and contain the infection. So those are some of the areas that we'd like to highlight. And then at this point, I'd like to invite Professor Abdul Karim to come forth and do his presentation. And then we will also invite some of the other specialists to also share with us some of their matters. Thereafter, we'll open up for the question. Thank you very much, Professor Abdul Karim, if you could take the floor.
Thank you very much, Minister. It's indeed a pleasure and an honor to share with you this evening some of the data and to describe some of the patterns in the COVID-19 epidemic in South Africa. I am speaking to you in my capacity as the chair of the Ministerial Advisory Group on COVID-19. I want to take this opportunity to introduce some of my colleagues and fellow members of the Advisory Committee who are available on this Zoom call and who will be available to answer questions. If you look at the pictures at the top line, I'll start from the left-hand side. Dr. Kami Chetty from the National Health Laboratory Services, Professor Shaheen Mehta from the University of Stellenbosch, and Professor Mark Mendelsohn from the University of Cape Town. Now, Professors Mehta and Mendelsohn led the initiative within the Ministerial Advisory Committee looking at the issue of fumigation tunnels and human spraying, and they will be available to answer questions on that. Professor Helen Rees, who is from the University of Witwatersrand, and she's also from the Health Products Regulatory Authority, and she led the technical working group in the Ministerial Advisory Committee that looked at the path forward in terms of how to proceed with our new prevention strategies. Next to Professor Rees is Professor Sitembiso Velapi, who is the head of pediatrics at Baragwanath Hospital and a professor at Wits University, followed by Dr. Mo Archery from the University of KwaZulu-Natal. Professor Velapi and Dr. Archery led a technical working group in the Ministerial Advisory Committee that looked at the issue of children, because both are pediatricians, looking at the issue of what is it going to take for us to have children go back to school in relative safety. And then finally, Professor Jessine Meyer-Rath, who is from the University of Witwatersrand, and she is the person who is one of the leaders of the technical working group in the Ministerial Advisory Committee, looking at how we should best use our available resources in the COVID-19 tests that we have available. So it's my pleasure to have members of the Ministerial Advisory Committee available and in joining us in this call. What I propose to do in the next 15 to 20 minutes is I'd like to share with you an overview of what are we trying to achieve. And I find that it's always helpful to have a clear perspective about ensuring that we keep our eye on the prize and what is that we're trying to achieve. I'll talk about the coronavirus prevention toolbox, and I'll talk about some of the trends that we're seeing in the COVID-19 epidemic before I end off with touching on the issue of the hotspots and this particular stage of the response before making some concluding remarks. So the primary objective, the primary goal of the South African COVID-19 response is flattening the curve. And what do we mean by flattening the curve? Well, essentially, we are trying to avoid a rapid increase in new infections to the point where it would overwhelm our healthcare services. So if we look at what flattening the curve means, well, it's really a strategy that we are taking forward, and it's a strategy pretty much being followed in almost every country in the world, is in the absence of natural immunity or a vaccine, almost everyone may be at risk of the coronavirus infection. And so there will come a time when the infection has an opportunity to take root, and when that happens, we will see increasing numbers that may need hospital care. So the reason for flattening the curve is to reduce the rate of new infections so that the peak is lowered to a level where hospitals can cope with the cases. So flattening the curve reduces the peak during the massive surge so it does not overwhelm healthcare provisions. And we know that hospitals that can cope with the patients coming in can provide better care and lead to fewer deaths. So let's look at what strategy in particular we embarked on as a country. Well, we embarked on a strategy to flatten the curve early. And we were able to do so because we were able to learn from the experiences of others. And that we learned that those countries that attempted to flatten the curve when the epidemics were at an advanced stage and had difficulty in achieving the goal of flattening. So we learned, especially from the experiences in the UK, that if you delay, and in the UK, they instituted a lockdown about a month or so after South Africa, that when you delay and you've got a very advanced epidemic, then you really have a challenge in flattening the curve. So we learned that early was better. And so we were fortunate in that we undertook these initiatives at a very early stage. So why did we attempt to flatten the curve early? Well, we tried to do that. We did that to try and achieve 4 things. First is that we were trying to slow communities goal. The first reason why we were trying to flatten the curve early was to slow community transmission. We wanted to avoid a situation where the virus became widespread in our community and was being transmitted. The second is that we wanted to get some time, and that time was to give us the opportunity to expand healthcare capacity, especially ICU and high-level care. And if you look at the picture on the right-hand side, it's unrecognizable that that is actually the Cape Town International Convention Center that is now being established as a field hospital. The third was to provide time so that we could better prepare and equip our hospitals, ensure that we obtained the necessary PPE and provided the opportunity for healthcare workers to get ready for the surge of cases that may be coming. And then fourthly, was to provide time to scale up our testing and our prevention strategies. And in this particular instance, our approach of instituting a huge community program where we've screened just about 13 million people. So we aim to flatten the curve early to achieve these 4 things. So why do we talk about flattening the curve? Why not talk about eradicating or eliminating this virus? Why don't we aim for a situation where we just get rid of this virus? Well, the reality is that it's very difficult to do so. It is very difficult to stop the spread of this virus. And the reason for that really revolves around these 5 characteristics. The first is that even before a person becomes ill with the coronavirus infection, for several days before they have symptoms, they are already infectious and they are already spreading the virus to others. And so household contacts become infected. People they interact with in public transport, in a range of different settings, can get the virus from somebody who hasn't yet shown symptoms. The second is that we have, and we think, because we haven't been able to measure this accurately in many parts of the world, including South Africa, but we think that somewhere between 20% and 50% of infections are very mild. So we call these asymptomatic infections, where the person does not know at all that they've acquired this particular virus. But even though they do not have symptoms, they are still infectious and they can spread this virus. The third is that this virus spreads rapidly, much more rapidly than we've seen with other infections, such as influenza. And so before we can even catch up with trying to find the cases, the virus has already spread. In that we know that it can infect, from each infected person can infect up to 2 others. The fourth reason why it's so difficult is because this particular virus is also associated with super spreading events. We saw this in particular in the one case in South Korea, where the first 30 patients, they were able to control the amount of spread by identifying all those who were in contact with the person, by doing contact tracing. They were able to put in quarantine and they stopped the spread of the virus. However, patient 31 in South Korea was infected. She went to church. She then went to a buffet lunch. She then went to the hospital where she had a test. And when she had done these things, she had exposed thousands of people. There were hundreds that became infected through the buffet lunch. So you get these super spreading events. And because so many people get infected, it's really difficult to find every one of those cases and to stop the infection from spreading. And then finally, even when you do get the spread under control, because we do not have adequate immunity, you will always run the risk of repeated waves, of outbreaks and the new epidemics coming. For example, Singapore, which for many days had the epidemic under control, with very few and almost no indigenous infections occurring. And then suddenly they have an outbreak. Several hundred cases occurring in one particular residential complex for migrant workers. So it is very difficult for us to simply eliminate this virus. And so we have chosen an alternative, which is to flatten the curve. So how do we do that? Well, most countries in the world have chosen to go with a strategy that was first implemented in China, known as a lockdown. We've in the process of a lockdown, we are now in the easing of the lockdown. So we know all of the challenges that that is associated with, but we also need to get some understanding of what did it achieve. Well, let's have some idea of what happened. In the 3 weeks from the time we had the first case to the date of the lockdown, the epidemic was growing at a rate, and I've used for this purposes of this presentation, something called doubling time. So how long does it take before the number of cases doubles? In other words, the size of the epidemic doubles. Well, in the 3 weeks before the lockdown, the epidemic was doubling every 2 days. And indeed, if it continued along a trajectory like that, we would have had an epidemic that we would have been very similar to what we see in the UK, which is tens of thousands of deaths and hundreds of thousands of infections. But since we instituted the lockdown, and over the period of the lockdown, the doubling time diminished drastically from 2 days to 15 days. So now the epidemic is only doubling roughly once every 2 weeks. So we went from doubling. Can we mute this line, please?
Prof, can you unmute yourself, please?
So we went from a situation
where the epidemic was doubling every 2 weeks. Since we started easing the lockdown on the 1st of May, that doubling time is starting to slowly quicken. We are now at a doubling time of around 12 days. If you look at the situation that we have been trying to deal with, is now we are trying to implement the full coronavirus prevention toolbox. One of those tools is the lockdown, and that's what we have implemented, and now we are in the process of easing that. But it has come a time now, because we need to be using many more of our tools. we need to understand what they are. And I've provided this picture to give you some idea of the spectrum of tools that we have. And looking at these tools, can you hear me? Okay. So if you look at the spectrum of these tools, what it tells us is that we need in each setting. So if we are talking about a mine, if we are talking about public transport, if we are talking about a shopping center, in each of those situations, we need to understand what the risks are. And once we've identified what those risks are, we need to choose the correct tools for it. So that if we are dealing, for example, with a problem of trying to, let's, for example, say, trying to remove a screw, we wouldn't go around trying to use a hammer. Instead, we'd use a screwdriver. So we've got to pick the correct tools to solve the particular problem that we are dealing with. And that's why this toolbox is important, that we pick from the toolbox a combination of things that will mitigate the risk and enable us to go about trying to capture as much of our daily lives as is possible without raising our risks unnecessarily. One of the issues which is causing great consternation is a tool that's being used which is not in the toolbox, and that's the process of human disinfection. And they are particularly being used in tunnels. This should simply not be permitted. Spraying of humans with chemicals and putting humans through fumigation tunnels is potentially dangerous. It can damage the eyes, it can cause skin rashes, it can affect breathing. There is little or no evidence for the safety of the chemicals that are being used, and their side effects are largely unknown. And to cap it all, it's not just that these are potentially harmful, it's that there's no discernible benefit for coronavirus prevention. The virus simply does not enter the body through intact skin. The coronavirus, when it does cause infection, enters through the mouth, the nose, the eyes. The spraying does not help in any one of those conditions. So what we have in these fumigation tunnels and human spraying is a harmful practice that has almost no benefit. So what should you be doing instead? Or focus on the toolbox. And one of the key things to do is to spray your hands with a hand sanitizer so that any virus that may have been picked up from surfaces can be killed. I cannot stress enough the importance of not going through one of these fumigation tunnels. So let's look at one of the strategies that's a key part of our toolbox, and that's scaling up testing. In South Africa, we have made very good progress in terms of scaling up testing. But with that progress has come many challenges. One of the key challenges is that we as a country, together with the rest of the world, are all trying to get hold of the same test kits. And that becomes a challenge, that we are having a real problem in ensuring that we can obtain enough of these test kits. And right now, one of our particular challenges is to obtain enough of the extraction kits. And so we've had to prioritize our testing. We've prioritized it to hospital patients, healthcare workers, and outbreaks. And if you look at the way in which we have been increasing our testing, it's simply a matter of time before we were going to reach a situation where we would have difficulty obtaining new kits. And that has now occurred. And there are many repercussions from that that you will hear from Dr. Chetty later on this evening. So one of the issues that's important for me to comment on, because I had proposed previously that we look at the number of cases per day and use the confidence interval of 45 to 89 as a way of judging whether the number of cases was going up or down. But that approach is only applicable when the number of tests are not changing substantially. But you can see very obviously from the orange bars that because the numbers of tests have been increasing so dramatically, it is no longer feasible to look at simply the absolute number of tests. So we have to come up with better metrics, better ways of understanding what's the situation in the epidemic. And it's illustrated when you look at the first week of the lockdown. So in the lockdown period, during that first week when the lockdown started, the number of cases declined from 111 to 76. But at the same time, the average daily number of tests went from 2,234 to 3,928. So the number of tests was going up, but the number of cases was going down. Compare that to the situation in the first week after the easing of the lockdown, where the number of cases went up from 242, and that's the number of cases, the daily average, to a situation where we have 369. But that is accompanied by a dramatic increase in the number of tests, from 12,000 odd to just over 15,000. So you cannot simply look at the number of cases any longer. That was only feasible very early on in the epidemic. So what is it that we should look at this time? Well, there are many different measures. We look at in the Ministerial Advisory Committee and among epidemiologists, we look at a range of different measures. We call them the reproduction number. We call it the effective reproduction number. We look at doubling time. Well, there are many things. The WHO recommends several of these measures. But one of the things that's proven to be very useful, and it's widely used in many countries, including the US, is what proportion of the tests that are being performed are positive. And I'll refer to this as the positive test proportion. So if you look at this graph, it provides for each week since the start of the coronavirus epidemic, it provides the total number of tests that we did in each week. So the first week in the epidemic, we did 443 tests. The following week, 723. The following week, 1,998, and so on. And so that's listed with the N. If you look at the most recent week, which is not a complete week yet, we've performed 39,170 tests. So what we need to look at is what proportion of those tests are positive. And you can see that since the initiation of the lockdown, we have had our positive test proportion has been steadily declining, and it's remained within this narrow range between 1% and 3%. And it's giving you some idea, about 3.4%, it's giving you some idea that overall in the rest of the country, because this excludes the Western Cape, that in the rest of the country, besides the Western Cape, the overall level of positivity is low. And it indicates to us that the level of community transmission by extrapolation is low. And we can divide these samples into different strata. So if we look at hospital patients only, the percentages don't go up that much. If we look at only our community screening, the percentages go a little lower. But overall, it doesn't matter which group you look at, the percentages remain low. Compare that, remember that this is the other 8 provinces, compare that with the Western Cape. And what you see is a dramatically different picture. In the Western Cape, you can see how week by week, the number of tests have been going up. So if you look at 4 or 5 weeks ago, they were doing about 10,000 tests that week. went up to 12,000 tests, 13,000 tests, almost 15,000 tests. And so as you look at the increasing number of tests, what you see is that not only are the tests increasing, but the proportion of tests that are positive is also increasing. And if you divide that into hospital patients and community or contacts or outbreak investigations, you see that these increases are mirrored in both situations. So this tells us that we have a different scenario in the Western Cape compared to the rest of the country. And in this graph, I put the same two sets of bars together so you can see the comparison. That in the Western Cape, we are dealing with an epidemic that is growing rapidly. In the rest of the country, we are dealing with an epidemic that is at a low simmering level. What is the situation? Why are we seeing this picture in the Western Cape? Well, we can look at it across a range of indicators. That when you look at the Western Cape, that you see that not only is the number of cases high and the incidence risk is high, but they account for just around 2/3 of all our cases, and they account for about 2/3 of all deaths. And that is reflected in the continuity between having cases, having hospital admissions, and having deaths. It would be unusual, if not impossible, to have a situation where you would have a dramatic number of cases that you simply don't know about because it would manifest either in hospitalizations or in deaths. So we can see that the picture in the Western Cape is substantially different from the remaining provinces. There's another way of looking at that. If you look at the incidence risk, you can see that all of the provinces are at the bottom end of this graph. But the line that's rapidly rising is that of the Western Cape. So what is responsible for this increase? Or how can we measure this increase before I talk about what's responsible? We can measure it in many different ways. I've chosen to use doubling time. And if you look at the doubling time in the Western Cape, you can see that we went from a doubling time during the lockdown of 18 days to a situation now where in the Western Cape, it's doubling every 9 days. When the epidemic gets into its full swing, generally the doubling time is around 4 to 5 days. Now you have to be somewhat circumspect at looking at these data because you do need to have adequate numbers of tests being done in order to be able to get a very accurate measure. So the interpretation of these numbers always has to be tempered with an understanding of the limitations of these data, in that we simply do not have enough tests and that we have backlogs in terms of being able to obtain the accurate numbers on a daily basis. Compare the 9 days doubling time in the Western Cape to Gauteng, where the doubling time is 24 days, or KwaZulu-Natal, where it is 26 days, or the Eastern Cape, where it is 12 days. So if we look at this situation, we again are getting a sense that the Western Cape has a very different picture. If you look at what is driving this, these are hotspot maps that come from the Western Cape, and I'm deeply grateful to the Western Cape Department of Health for providing these. They give you some idea of what the actual distribution is. And in the Western Cape, what occurred was in the latter part of the lockdown, the strict level 5 lockdown, we saw outbreaks occurring. Most of them occurred in grocery stores and supermarkets. And when you have those kinds of outbreaks, they very rapidly lead to a situation where customers lead to infecting staff, or staff get infected in the community and come into the store, they contaminate the store, it spreads to other staff, spreads to customers, and before you know it, you now have widespread transmission. But what's important is that in the Western Cape, they've been able to identify these hotspots. They have been able to identify the sources of these transmissions. And it's very likely that in many of these hotspots, they were associated with super spreading events. We don't have definitive evidence of that, but it's suggestive that these outbreaks were accompanied with super spreading events. And the Western Cape has developed a very specific hotspot strategy that's focusing on dealing with this problem at a very local level, because we've got to try and slow the number of cases in order to ensure that we are able to cope. And so when we look at our response, when I first described our response in its 8 stages several weeks ago, I said that we were completing the first 4 stages, and we are now at the tail end of stage 4, and we are about to end active case finding from community screening. And we are now in full swing working on stage 5, which is hotspots, where we are trying to identify those particular points at which the epidemic is going to take off. I described it in my previous presentation as we have to look for the flames and we have to douse them before they become raging fires. And so that means we have to have surveillance. It means we need to be able to identify where these hotspots occurs, which means we have to be able to test. We have to intervene. We have to understand why the virus is spreading. And we need to have outbreak investigations and try and turn off the tap. We've got to try and find the reason for the spread and stop that from occurring again. And so we knew that as the lockdown comes to an end, that we should expect a rise in cases and we should expect outbreaks. We are already seeing those outbreaks, whether it's in the Albany Bakery or whether it's in Joburg's Mediclinic or whether it's in a Dis-Chem store or in the prisons. We will see outbreaks. Just this last few days, we saw an outbreak in one of the mines. This is how the virus spreads. It is not a reason to panic. It is not a reason to shut everything down. It is simply the basis on which we have to go in, establish who has picked up the virus, establish what the size of the flame is, establish why it occurred, and then figure out what are the intervention steps to stop it from spreading any further. It's a systematic approach to dealing with outbreaks. So let me conclude by just pointing out one last element, and that is that when we look at how our epidemic curve compares with others, that there is little question that our epidemic curve, if it followed the inflection point and continued on its exponential growth, we would have seen a curve, something like what we see in the United Kingdom, which has a similar population size to South Africa. Instead, our curve has been flattened. You can see the way in which the light blue line is now at a much lower level than the purple United Kingdom line. But it's not that only. South Africa's line is among those epidemics that are the least severe of all of the epidemics. We are keeping company with South Korea, Australia, and so on. However, if we do not ensure that we continue using our prevention toolbox, that line could very easily rise rapidly and join the lines that we see in the UK and in the US. So that brings me to my concluding remarks, that South Africa has averted the exponential curve we anticipated and that we were expecting to see in March. We have flattened the curve insofar as we have started to flatten the curve, because flattening the curve is not a single event. We are going to need to continue our efforts, and we're going to have to continue this for months, years, and just depending on when and if we can obtain a vaccine. The time that we have been able to acquire through our interventions to date, through the state of disaster, through the lockdown, through the implementation of social distancing, hand washing, and so on, has given us time to improve testing, to build healthcare capacity, to establish field capabilities for healthcare, PPE procurement, but there is lots more still to be done. Testing coverage was improving, but has run into serious supply problems. Mitigating risk as we return to work by using combinations of tools from our prevention toolbox is going to have to be part of our new normal. In essence, there's simply no room for complacency. We expect the case numbers will rise. Depending on what the migration patterns are from the Western Cape, we may see a continual seeding of the epidemic from the Western Cape into the Eastern Cape. And that may be the next point at which we will see an outbreak occurring. We are expecting outbreaks. We are expecting to see these flames. The Western Cape is simply an early indication of what we may see in the rest of the country. I sincerely hope that as we watch and as we learn from the experience of the Western Cape, we may be able to avert some of the rapid growth in the epidemic that we have seen in the Western Cape. Indeed, we are learning a lot from the experiences in the Western Cape as we focus on stage 5, on identifying hotspots and intervening, and essentially finding the flames so that we can prevent raging fires. Just remains for me to thank all of the people who've contributed data to this presentation and to all the hardworking people tackling the coronavirus epidemic, especially our healthcare workers on the front line. Thank you.
Thank you very much. Thank you very much, Professor Abdul Karim, for that very enlightening presentation. Would like to call onto the stage now Dr. Kemi Chetty to table a brief presentation on the testing within the National Health Laboratory Services. Dr. Kemi Chetty, please come on stage with your presentation.
Thank you very much, Minister. I'm just going to share my screen. Can you see the presentation?
Yes, yes, we can.
Yes, we can. Please proceed.
Okay, thank you very much, Minister. I'm going to focus on the unprocessed specimens of COVID-19 testing in the NHLS. As at 28th of May, the number of unprocessed specimens was about 83,000. And as indicated, despite a massive increase in the number of tests that we were performing in the NHLS, as you can see from the table at the bottom, our figures have more than doubled between April and May. So you can see that in March, we did about 6,000 tests. In April, there was a huge jump. We went to 94,000. And in May alone, we've done about 232,000 tests. But despite that, the number of samples that we were receiving exceeded the capacity that we had. And that's why we ended up with a number of tests that are unprocessed. Also, just to give you an example of how we are trying to escalate the number of tests that we are doing, during this week, just between Monday and Thursday, that's about 4 days, we've already done about 39,000 tests. That represents about 42% of what was done in April alone. Just to give an idea of the reason as to the unprocessed specimens in May, the problem really started in the first week in May when the demand exceeded supply. And that was due to a global shortage of the extraction and high throughput kits. And I'll talk a bit around the high throughput kits. We also, the month of May was a really problematic month with a number of logistical issues. Some of our suppliers had interruptions with production. Their factories had to close down when patients tested positive. There were lots of flight cancellations from a number of different countries. We had problems with custom delays. We also had lots of problems with closure of services during the public holidays. One of the other issues that we also had to deal with is that it's not a normal demand and supply issue. When we normally order tests, we determine the number of tests that we want. We place an order to the supplier, and the supplier gives us those tests. But we had a problem with the high throughput test kits, which had only been approved in March by the FDA, and we had and because of that there was a production issue. So we couldn't, even though we were ordering the number of tests that we wanted to do per day, we weren't getting those supplies. With the high throughput test kits as well, the supplier decides as to what's the allocation for the different continents, and then that supply for the continent is then divided between the different countries. And this is because of the challenges that the suppliers are experiencing in production. The suppliers have indicated that this is the allocation that we would get. So regardless of what we've ordered, we get what the supplier can give. And we've been told a number of times that South Africa is in a more fortunate position than many other countries because the amount that we're getting is a larger proportion, even though for us, the amount that we're getting is very small. So just to give you an example, the Gene Expert, it's a machine that we use to do TB tests. We're also now using it for COVID-19. It's got the capacity to do about 15,000 tests per day. That's what all the Gene Experts we've got in the NHLS. But what we get allocated is 10,000 tests per week. Now that's just to give an example of some of the difficulties that we're having with regard to supply. This table shows you what has been the unprocessed specimens in May. These numbers fluctuate. I often don't like putting these figures up because someone will say, no, but those numbers are not correct. But just to give you an idea that as we are processing tests, you can see there's reductions, but at the same time, we also are receiving tests. But this is a fair reflection of the backlog that the unprocessed specimens that we've had in May. So as of the 28th, we had about 83,000 tests that were not processed. This table, Minister, I won't go through the details of it. I think Prof. Abdul Karim has covered quite a bit. This gives you the breakdown of the number of tests that have been done in the different provinces for both the public and the private sector. The proportion of tests, he's commented, and you have commented that Gauteng has got the highest proportion of tests. That's followed by the Western Cape and then the Eastern Cape. Yet Western Cape has got the highest number of positive patients. But this table also shows the number of the unallocated, the backlog of the unallocated tests. These are tests that have already been processed, but as explained by yourself, these are the tests that there's not enough data and that the NICD then, and I'm sure the NICD will talk to this, then looks at being able to allocate these tests to a particular category. And it also comprises some of the foreign nationals. So just to give you an idea then of what's the basic lab processes and the types of machines that we've got, and I'm not going to go into too much of detail, but just to give you an indication that the the whole process of doing the tests is dependent on the type of machine that you've got, but it is quite a complex process. You start off with the preparation of the sample, and then we have the extraction of the RNA from the virus, and we have what's called reverse transcription of the DNA, and that's done by extraction machines, and then we have the thermocycler machines, which then look at the amplification of the DNA. This is just to illustrate that with certain of the machines, you need a separate extractor. So for example, we've got extractors called the Nimbus and the EasyMag, and then you take the sample from that and you put it into the thermocyclers, and that process in itself means that you have, these machines are not high throughput machines. So the amount of samples that you get from it may not be similar to what we would get with what we call the high throughput machines. And that's the second category of the Roche Cobus machine and the Gene Expert, which are really our workhorses. And that's why we're saying that these are the machines that, and the test kits that we desperately need more of. So we've got in addition to the Gene Expert and the Cobus, we've also got another machine called the Abbott M2000. But because of some of the difficulties that we have, we are now looking at diversifying, and we've bought a number of other machines, and I'll talk a bit around that as part of our risk mitigation strategy. This slide then shows that what is our testing capacity. And when we talk about our testing capacity, we're talking of what's the throughput that the machines can do. So what's the capacity of the machine to do the test if we have a full complement of the test kits and the extraction kits. So with our BioRad machines, we can do about 5,000 tests in 24 hours. And then with the Roche Cobus and the Gene Experts, we can do about 15,000 tests in 24 hours. So immediately you can see where the problem lies, because if we don't have enough test kits for the high throughput machines, that's already eating into our capacity, or not utilizing the capacity to its fullest extent. Regardless of that, you'll also see that we've been trying to push as much of the tests that we can. This gives you an idea then of the number of test kits that we've got. That's the PCR test kits. We've broken it down into the open platforms, and you can immediately see that in the country, we've got quite a few PCR test kits for the open platforms. So we've got over 500,000. We've made sure that we try to stock up on that. And the problem isn't with those PCR test kits for the open platforms, nor is it for the low throughput machines as the Abbott M2000. I've already stated that where the problem comes in is on a weekly basis, we get 10,000 Gene Expert kits and 10,000 Roche Cobus kits. That's what we should be getting a day, but that's what we're getting per week. And this is where our problem lies, because that's where the test kits are required. The second problem lies with regards to the extraction kits for the open platform. So I've shown you that we've got over 500,000 tests for the open platform, but the limiting factor is how many extraction kits we have in order to extract those viruses. And you can see that again on a weekly basis, we're getting about 15,000 of those extraction kits. And again, that's where our problems and challenges lie. But I will also tell you some of the innovative ways that we are trying to overcome these problems. This just gives you an example of the unprocessed specimens per province. And you can see that I'll discuss some of the strategies that we're trying to reduce the unprocessed specimens and prioritizing certain provinces. As I've stated before, is when you put these figures up, then someone will say, no, but we've got a bigger backlog in this province. And I just want to say that some of these figures also, I've given you the definition of what would be a backlog. So if it falls within your particular turnaround time of 48 to 72 hours, those numbers may not be included. But as I've also indicated, this slide also indicates that the numbers do change all the time, because as you process samples, you're also then getting in a number of samples. But again, the principle is to say, this is what we're facing with regard to unprocessed specimens, and we're doing our best to make sure that those numbers get reduced as quickly as possible. So how are we looking at the management of those unprocessed specimens? So we have, together with the Department of Health, have looked at a targeted testing strategy. I'm not going to go into a lot of detail. I think there is going to be a presentation with regard to that. Prof. Abdul Karim did speak to it. But we have looked at prioritization of different test categories. And the categories that is prioritized are the in-hospital tests, patients under investigation, contacts, and critical care workers. We've issued an advisory to our laboratories to color code the testing samples based on those priorities, so we're able to process that as quickly as possible. And I need to assure everyone that the inpatients and the patients under investigation, that we make sure that we try to get those tests done within the specified turnaround time. I know that there were hiccups, but right now we're working on making sure that all of that gets cleared. Our biggest backlog of unprocessed specimen lies with the community screening and testing. The other priority patients have been prioritized. We're also monitoring the positivity, the rate of positivity in the provinces, and we're prioritizing our resources to the high positivity hotspots. I'm not going to go through the details here, because I think Prof. Abdul Karim has shown a lot of graphs, but this is just to indicate to you, we've grouped together the Western Cape and the Eastern Cape as two of the areas with high positivity rates. We monitor it on a daily basis to look at the number of positive cases we get in the different provinces. Here you can see the Western Cape, how high it is, and the Eastern Cape is the second challenge. Gauteng and KwaZulu-Natal are the other two groups, and you'd find here that whilst there are a number of positive cases, the positivity rate is fairly stable, of between 1 to 2%. In the other provinces of Mpumalanga, Limpopo, and Northwest and the Northern Cape, we go for days, as you can see on the graph, where there's no positive cases at all. And then we will get some positive cases, but the positivity rates in those provinces is below 1%. So you'll see also in the Free State had a problem, and this is, sorry, just for the month of May. Free State had a problem with the different incidents, but we've been closely monitoring it, and the number of positive cases, this is just in the NHLS samples, there has been zero for a number of days, and the same in the Northern Cape. Part of what we are doing with regard to the unprocessed specimens, the Minister of Health has requested us to prioritize the Western Cape because of its high positivity rate, and containing the epidemic in the Western Cape is going to be extremely important, not just for the Western Cape, but for the whole country. So for that reason, we've started looking at our high throughput test kits, and we have prioritized the Western Cape to get the major part of that. So this week, we took about 8,000 of our 10,000 gene expert kits and sent it to the Western Cape. By the end of this week, they would have, Western Cape would have received another 10,000 high throughput kits, both gene expert and Corpus. And what our intention with that is to just try to reduce the backlog to the Western Cape so that we don't have any backlog. But importantly, it's to identify the positive cases in order to be able to contain the epidemic. Over and above that, we've prioritized the Western Cape for new equipment that has been allocated. The Western Cape, when it started off, did not have a Cobus 6800. We procured one for the Western Cape, sent it through to the Greenpoint laboratory. We've procured 3 additional extractors because of the difficulty that they've had in extraction. We've bought additional PCR machines for the laboratories, and to the extent now that our laboratories don't have enough space to take more machines, but we are finding solutions with regard to that. And we've opened up the Greenpoint laboratory, which has been capacitated as an additional testing site. It's become one of our very high throughput laboratories with the number of tests that it's doing. The other province that has been prioritized is the Eastern Cape, but we also have a plan in place to eradicate the backlogs in provinces that are not as affected. For example, the Free State. By the end of next week, the Free State won't have a backlog, and we'll be systematically doing that with all of the other provinces. We've improved workflow through our laboratories. We've now using the innovative methods of manual extractions, which including heat activation and lysis. And this has been done together in collaboration with the private sector, where we've been exchanging ideas as to what do we do where we've got a shortage of extraction kits. And I also need to point out that the problem with the shortages of kits is not just an NHLS problem. It affects the private sector as well. So we're very closely collaborating on a number of innovative ways in order to reduce the problems that we have. We've also engaged the academic research laboratories, and we're working closely with them to also look at how we would be able to utilize their spare capacity, or their capacity as part of our surge program. And we're very grateful to the Department of Agriculture and Land Reform and Rural Development, where Minister Didiza and Minister Mkhize facilitated 7 extraction machines, as well as 38 mobile units that we will be able to use in our field work. I'm going to go very quickly through this. So one of the problems that we've had is that we normally try to standardize our equipment between laboratories. But having done that, we discovered that in a situation like the pandemic that we are facing, having single suppliers tends to create a problem, because if that supplier can't supply us with test kits, we just have a complete bottleneck and we can't proceed. So what we've done now is we've diversified the suppliers, so that if one supplier doesn't have a test kit, we go to another supplier, and we try that. And so what we've done is we've ordered some time back new equipment, but the lead time has been long. But this is the new equipment that's currently getting installed, and the Kingfisher and Hamiltons will be installed in June. We've also bought a number of new PCR instruments for amplification, because again, our strategy is to say, if we improve on our extraction, let's also improve on the amplification with new machines. So that has also been done. We've also managed to procure more gene expert infinities, just to make sure that our TB program also doesn't get affected. We'll be able to continue making sure that we can conduct our TB tests with the new machines. So in conclusion, I just want to we have upscaled our capacity within a very short space of time, but we're very much aware of the fact that whilst we've upscaled that capacity, the problem that we're sitting with the unprocessed specimens has to be sorted out, and we're committed to making sure that we do sort those unprocessed specimens out. And as you can see, we've been increasing our outputs to reduce the backlog, and we remain committed to delivering quality testing, and we'll provide all the support that we can for the targeted testing strategy. So thank you, Minister.
Thank you very much. The CEO of the National Health Laboratory Services. May I request Dr. Tumi Meche Mukukutleka, who is the CEO of the South African Health Products Regulatory Authority, just to give us a sense in 5 minutes what they have done to license under emergency and under routine processes the various products that might be useful for purposes of increasing our capacity. And so if we just take us through briefly. After that, I'm going to ask that Dr. Natalie Mayet or Kerrigan McCarthy, just for about 2 minutes or so, whoever is available, to take us through the issue of unallocated, just how we deal with it and how that has come about, and then we can then move from there. We'll just make it very brief. Dr. Tumi, please.
Thank you, Minister. Can you hear me?
Yes,
you can. Please proceed.
Good. Thank you very much. So I'll be giving a presentation from SAHPRA, which is the South African Health Products Regulatory Authority. This presentation focuses only on diagnostic tests. We also regulate medicines as well as other health products. So just an overview, since the pandemic, we have received a total of 71 applications for molecular tests. So that is the PCR that Dr. Chetty referred to earlier. We have approved 23 of those for use. In addition, we have received 164 applications for serological tests. So these are the antibody tests. So this 164 includes both those that are point-of-care serological tests as well as laboratory-based serological tests. To date, we have recommended 20 of these to be validated through the National Health Laboratory Services. Of these 20, one of the serological point-of-care tests has been authorized for secondary validation. And the reason why we're doing the secondary validation is that many of you would be aware that a lot of these tests have very varied performance. You may have seen earlier during the pandemic, we had countries such as Spain, such as the US, as well as the UK, recalling some of these tests because at this point they have this varied performance. And so it is imperative for us as a regulator to ensure that the tests that we approve at least give us performance that gives us comfort in that we're not going to sit with a high proportion of false negatives and false positive tests. And then lastly on this slide, we have 3 lab-based serological tests that again we have authorized for validation by the NHLS. What we typically do when tests are submitted to South Africa, if these are recommended, if these are registered with the regulators where we apply what we call reliance, these we automatically approved. However, with the pandemic, we've seen that there's been a number of developers that are not necessarily registering their tests in these countries where we have reliance mechanisms. And again, that's why we need to put in place these validations to ensure that as a country and as a regulator, we are satisfied with their performance. I thought I'll also touch on the process that we follow so that the listeners as well as industry can understand how it is that we get these products to a point where we validated them. So if the products are imported, they submit their license to SAHPRA together with their technical dossier. If they meet the recommendations of SAHPRA in terms of our specifications, we then send them for secondary validation at a lab that we will communicate to them. And in this case, it's largely been the NHLS. If they pass the presentation by if they pass the validation and they meet the criteria as we have set forth, when the tests are evaluated by the NHLS, they will then get a Section 21 license that is issued, and we will authorize the kits for a very specific use that we will determine and communicate to the applicant. In the event that there is a local developer, and we're seeing a number of these, and we've actually had a workshop with them that was facilitated by the Department of Science and Innovation, where we communicated the process that we follow. So for local innovators and manufacturers, what they start doing is that once they've got their kits ready, they will then send them first for the primary validation by the NICD. Once they have then that data, they will then submit that to SAHPRA. We will evaluate that data. And if they then meet the criteria, they will then be authorized, again, Section 21, with a very specific indication of the use. So we're very much cognizant of the need to support locally developed tests. So I'm not going to go into too much detail on this slide, but it's just to give the country a sense of the numbers that we're dealing with as a regulator. As I mentioned, we've received about 164 applications of serological tests, and there's very clear process steps that need to be followed. And while we have this platform, I'd also like to make a request to industry that when we send you requests and we require information and feedback from you on queries, we need you to respond timelessly, because what we're also seeing, as indicated here, is that there are delays that we're encountering because the applicants are not supplying the information in the required time. And the numbers that I've indicated here is what I've shared with you earlier. Typically, this process of registering medical devices takes SAHPRA anything between 3 to 6 months. However, being cognizant of the pandemic and the need for us to respond with speed in support of the labs, we've accelerated our processes. We've even published how we go about these processes, in that it takes us plus minus 18 days to evaluate serological tests and about 4 or 5 days to evaluate the PCR tests. So just to end off, this is a list of the PCR tests that we have approved, and this list is also available on our website. As soon as we've got serological tests that have been fully validated, they meet our criteria, we will also publish those on our website. Minister, I'd like to end here. Thank you very much.
Thank you very much, Dr. Tumi Simetema-Kupoteka, the CEO of the South African Health Products Regulatory Authority. I am fully aware that that whole team, the board, the staff have been working very hard, 24 hours over weekends, to try and fast-track this one in response to our call for emergency approval to assist us to be able to cope with the COVID-19 pandemic. So I want to say thank you very much for that presentation. Let me ask now Dr. Natalie Mayet, if you could, just for about 2-3 minutes, just to talk about what are the issues that create the unallocated backlog, and what are some of the back office work they do in trying to ensure that these are put onto stream. Just a 2-3 minutes, brief comment. Dr. Mayet, are you around? Okay.
She is on.
Yeah, okay. Let me see if someone else from the, Dr. Kerrigan McCarthy, you might also comment on that. You probably come back on another comment later, but you will just deal with that aspect. Any comments briefly?
Thank you, Minister, for the opportunity to respond to this question. So every day, the National Institute of Communicable Diseases has a team of epidemiologists who, together with the IT department of the NICD, review the data coming into our central data warehouse in order to provide your office with the daily statistics. So the process includes a review of the new cases that have arrived during the day from both the public and the private sector. We have a cutoff time of 12 o'clock the previous night, and we include all the cases that have arrived for that previous 24 hours. We then review the available information that we have, and sometimes when specimens are not, the specimen request form is not completely filled in by the requesting doctor, there is missing data, and we are then unable to allocate that particular result to a province. However, our team works with the provinces to complete this data and to make sure that the specimen can be allocated in due course. That's from my side. I see Dr. Mayat is on the call, and perhaps she'd like to add something to that. Over.
Dr. Mayat.
Good evening, Minister, and good evening to the members of the Ministerial Advisory Committee and to viewers. Thank you, Dr. Kerikan has outlined the process. I just need to, to highlight that COVID-19 is a notifiable medical condition, and it has been in the regulations since 2017 as a respiratory disease caused by a novel respiratory pathogen. And why I highlight that, Minister, is because this is required to be reported within 24 hours by all healthcare practitioners who are seeing a patient with a notifiable medical condition, by all laboratories in the public and the private sector, and by all our medical aid administrators. And this provides the framework for us collecting this data and pulling this data through from the private sector and the public sector laboratory data systems, and we utilize and have a cutoff time at 12 o'clock every night, and then start processing that data from 4 a.m. So as Dr. Kerikan has indicated, a team of epidemiologists, and we acknowledge the work that they do, process all of these tests from the NHLS system and from the private sector and allocate them to a province. Now, there's a lot of complexity in that process because you may have a driver who works in the Eastern Cape and travels to the Western Cape, gets tested in the Western Cape, but resides in the Eastern Cape. He needs to be allocated accordingly. You may have somebody who resides in Mpumalanga who goes to Pretoria for a test. So we cannot regard that positive test of that individual in as a Gauteng case, but as a Mpumalanga case. So that happens on a daily basis in terms of apportioning and allocating tests to individuals. The NHLS has also collects test data. So that means one individual could have a number of tests. In fact, we have one person in our database who's tested 15 times. The 13 tests have tested positive, one test was indeterminate, and the last test was negative. Now, we cannot count this person as 15 people. We have to count him as one person tested 15 times. So that's the filtration and the sifting process that the teams do on a daily basis. And then we also confirm if there's missing data, if there's sometimes an individual may write their address as the person who's responsible for payment. And if it's a student, often the person who's responsible for payment lives in a different province. So we have to filter all of these, clean up this data. And so when we present the case data on a daily basis of the positive number of cases, we are aligned with our provinces to make sure that indeed they are allocated appropriately and correctly. And that's the process. And I would like to thank and acknowledge the teams who do this, starting at 4 a.m. In terms of processing all this data. So thank you, Minister, for giving us the opportunity. I would encourage all our healthcare professionals to continue to notify this as a disease, because that certainly will give us the insight into the determination of how this epidemic unfolds. And thank you, Minister.
Thank you very much, Dr. Mayet, Dr. Mkhize, for that explanation. I think it's a very important explanation because every now and again we have had complaints from the media, from Twitter, people asking why aren't we getting these things at 8 o'clock in the morning every day? And they ask why aren't we getting them, at 12 o'clock and so on. At least if everyone would appreciate that there's a lot of disaggregation that has to be done behind the scenes to be able to get a proper allocation. In some of the cases, the provinces have actually allocated people to go and sit in the laboratories to try and shorten the process of identifying the individuals. There have been a few instances as well where the MECs had to call to say the numbers of patients of positive cases that have been attributed to them are not as such, and so they're going to then publicly announce that the numbers are not that. And so we have to deal with that to say, yes, they have to announce that so that you can go and track the individual because someone would be attributed and yet they are not found there. The other aspect that we should also note is that in the early days, when lots of non-South Africans who got tested, and when we disaggregated the data, we realized that some of them were actually not even South African. So that's what sits in that pool of backlog unallocated numbers, which is an issue that really requires a lot of attention. If there's an understanding of the work that has to be done behind the scenes, sometimes it takes until very late to be able to confirm some of those numbers. But thank you very much for that. Let me then ask Dr. Anban Pillay and Dr. Yogan Pillay to just quickly give us a sense of readiness in terms of the beds and PPEs, just briefly, and then we will then move to take the number of questions that are coming through. If we could send them to the administrators, they'll come to us, and then we'll then send them to those who must respond to those questions. We've already received a few of those questions already. And so Dr. Anban Pillay, the Acting Director General in the department, and Dr. Yogan Pillay, the Deputy Director General, who can just take us through some of the issues in terms of readiness. You've heard that part of flattening the curve was to try and expand our health services so that they can cope with the new numbers that are coming through. So if we could just ask you to come through on that, Dr. Anban Pillay.
Thank you, Minister. If Sibu can just open the slide so I can just disable the screen sharing so I can get in.
Dr. Pillay, you may share your screen now.
Okay, thank you. Can you see that?
Yes.
Yes.
Yes, thank
Okay,
you. We can
great.
see.
Thank you. So I'm just going to go through the hospitalizations. So this slide gives you a sense about the number of cases, the recoveries, as well as the deaths. The cases is the cumulative number of people that have been tested positive across the country in the various provinces. That's reflected in the green bar. The blue bar refers to the recoveries, those that have been infected and have recovered. And the orange bar refers to the number of deaths. You can see that the Western Cape has the highest number of cases, positive cases. There's a significant number of recoveries as well. And there's 406 deaths in the Western Cape, which is the highest. So the number of active cases, which is the burden of disease at any point in time, is the total number of cases minus the recoveries as well as the deaths. You can see across the rest of the provinces, largely this is fairly low, except the Western Cape, where it's quite high. This second slide talks about the hospitalization data, and we're particularly focusing here on high care ICU and ventilation. You can see that the high care data is reflected in the yellow bar, the ICU data in the dark green bar, and then the ventilation in the dark blue bar. And what you can see as well here that the Western Cape has the highest number of patients that are in ICU, as well as those that are on ventilation and those requiring oxygen. In the other provinces such as KwaZulu-Natal, Gauteng, as well as the Eastern Cape, we have many of them are hospitalized, but very few of them actually utilizing ICU or being on ventilation. So at this stage, the demand for ventilation or ICU is fairly low, except obviously in the Western Cape, which is currently having a surge in the number of cases. In terms of quarantine beds, quarantine are sites where those that may be infected are kept in order to establish whether they're actually infected or not. And these are the number of beds that we have across the country. In total, we have 35,759 beds. Not all of these beds are occupied, and of these we have activated or utilized 36% of the beds across each of the provinces. This is where persons are unable to quarantine at home, or South Africans that are being repatriated are placed in quarantine sites across the country. Clearly, the province with the most quarantine beds that are activated is Gauteng, simply because most of the repatriation flights arrive in Gauteng, and so people are quarantined in Gauteng and then they move over to other provinces. And the Western Cape, given the high burden of disease currently, have a significant number of beds that are activated as well. This is a slide indicating the amount of PPE that we have. We have implemented a system of what we call the stock visibility. It's an electronic system, so facilities in the public health sector send us their stock levels, and this is updated on a weekly basis, and the provinces with a high burden are monitored much closer. So the PPE that we monitor are the masks, such as surgical masks, N95, FFPs, etc., gloves, gowns, aprons, as well as sanitizers, boot covers, digital thermometers, disinfectants, etc. And you can see across each of the provinces the quantity of stock that's available. So if you took, for example, masks, surgical masks, in the Western Cape they have over 9 million, and in the country we have 26 million. We clearly will move more stock to provinces that have a high burden, such as the Western Cape currently, and we anticipate as the burden increases in other provinces, we will then move stock to those other provinces as well. So this system is intended to monitor the stock levels across provinces and intervene where these problems may arise. And then finally, just to give you a little bit of a sense about what our bed status looks like, I think it's important to link this to the first slide that Professor Karim presented, because our objective is to try and reduce the height of the curve. So we reduce the number of people that are requiring beds at any point in time so the health system can cope. On the left-hand side of this table, you can see the total number of beds that we have. We also have separated this out into general beds and the critical care beds. And on the right-hand side, these are the beds for COVID-19 patients. We have the general beds that have been allocated for COVID-19. You can see in total, these are about 12,000 beds across each of the provinces. We have then the critical care beds that have been allocated. These are 2,309. And then additionally, we have the field hospital beds, which are 13,129 at this stage. So in total, we have about 27,467 beds that have been allocated for COVID in response to the potential surge in the number of cases that would come through. Thank you, Minister. I'll stop there.
Thank you very much. I think it should also just be noted that most of those field beds, it takes a period of about 2 to 3 weeks to put in place. And so what we have taken is an approach that says that when we see the numbers are indicating that those beds may be undermined or swamped, we then will be asking the provinces to increase the beds. That means they'll have about a month or so to be able to adjust to the new numbers that will be required. So there's a kind of alertness to look at how we can actually move the numbers up as the trend of the pandemic is actually showing itself. Some of the modelers who put up the earlier models actually had a very different approach. They thought the first surge is going to come into Gauteng, followed by KwaZulu-Natal. So it's very, very important for us to say, whilst we observe what the models have been showing, but we are watching numbers on the ground. What is our data telling us? Now, in this case, as what you have seen from Professor Abdul Karim, the data is indicating that the numbers and the timing on the Western Cape is moving faster, and therefore there has to be, an equal response in supplies of additional beds of PPEs, as well as also on human resources, and all of this is all in response to what the emerging pattern of the pandemic is showing. So I think at this point we should then take some comments and questions, but whilst we are going to be requesting for comments to be coming through, would I then ask if Dr. Kalua, the current representative of WHO, would maybe just have a word or two, just a minute or two, just to have some comments to make. And in the meantime, we're going to be announcing the questions and the responses there too. Thank you very much. Please, Dr. Kalua, if you could just come on board a couple of minutes.
Thank you very much, Honorable Minister, and thanks very much to all colleagues. Just a few comments, Minister. First of all, I'd like to say that from the perspective of WHO and also observing what is going on within particularly the Africa region, is that the response in South Africa was rapid, was decisive, and was very much based and informed by data. And that is a very important point that a number of countries from the region will have to learn from. If we go on to talk about the lockdown that was put in place and indeed bought a lot of time and allowed for a number of measures to be put in place, the easing of the lockdown that is ongoing has been formed very much by the data. And that particular process of easing down is in line with what WHO has advised, that countries should have gradual easing of lockdown. So the moving in South Africa from stage 5 to 4 to 3, and subsequently to other steps, other stages forward, is very much in line with what WHO has advised. And the extent to which the data is being used to look at hotspots and to have a differentiated approach is something that countries in Africa will have to learn from. Because indeed, South Africa is having to ease down the lockdown at a time when cases overall are increasing, and that would also be a case in a number of countries within the region. So the lessons that we learn from South Africa will be critical for informing other countries on how they should manage their response and also manage the lockdown. But as has been pointed by Professor Karim, the important point is the involvement and engagement of the public, in that each individual has to take into account and implement and adopt the various public health measures that are in place now. The hand washing, the sanitizing, the cough etiquette, the social distancing. And if each and every individuals begin to adopt this and complement the effort that government and other stakeholders are doing, I think we'll move a long way in addressing this pandemic. So, Honorable Minister, thanks very much. Just once again to say that if we can document what we're doing in South Africa, it will be valuable in informing other countries as they implement their own responses, as also they move towards easing their own lockdowns. Thank you, Honorable Minister.
Thank you very much, Dr. Kalua, for those very encouraging comments. And also thank you for all the support. If I may as well say that we are very grateful that most of the provinces have got technical support from your office, and we want you to know we appreciate all of that very important work. We've now been asked by media if we could start talking about the numbers for today, so we'll take now another 2 minutes just to deal with that issue. What we do is we're going to just share the numbers as you see them on the screen. At this point, I think it's important to indicate that South Africa, the latest numbers, cumulative cases are 29,240, with a new 1,837 cases in the last 24 hours. The national case fatality rate is at 611 at 2% as of today, 29th of May. The numbers of recoveries are 15,093, which is 52%. You will also again see the numbers in terms of the various provinces, the cumulative cases for the different provinces. Eastern Cape at 3,583, at Free State 231. I think you would have noticed when we were talking about targeting that when we said we're targeting Western Cape, at some point we actually targeted the Free State, and so we shift the targeting based on the numbers. So the Free State numbers have actually kind of reduced to the level that we are now seeing. Now, then in Gauteng, we're at 3,583, KwaZulu-Natal 2,428, Limpopo 170, Mpumalanga 112, Northwest 143, Northern Cape 52, and Western Cape 18,906. These numbers are indicating the variations between the various provinces. And the unknown over this period to be cleared is 32. And we'll also notice that on the same table, numbers of deaths have been indicated, with the largest number of deaths being from Western Cape. I think that constitutes very close to just about 75% of 67% of the deaths in the country. And then if you look at the cumulative recoveries, again, the numbers are indicated at 15,003. We can just move on with the slides.
Minister, no, this was just the one slide.
Oh, okay. All right. Then I think the one other aspect of this presentation would have been included in the figures that you raised earlier, and that basically talks about the fact that at this point we have done 680,175 tests throughout the country, and the new tests that were done were 24,052. And that is an indication of the numbers that were indicated from yesterday. We have indicated the numbers of deaths, and so we will not repeat those because they were all combined in the same slide. But we do want to convey our condolences to the members of the families and those relatives who have lost their loved ones. And we do also acknowledge that we have in the past few days also lost a number of health workers as well. And with all of that, we want to also thank the members of staff who we know that some of them have actually put themselves in a position where their own health is at risk because of the fact that the infection doesn't discriminate, but we will continue to ensure that they are protected and that they are given the necessary attention and treatment so that they can recover and continue the work that they're doing of serving the nation. With that, I would like to then, at this point, invite all the questions to be sent through to us. I would then check if any of these questions have been given to Professor Abdul Karim. Have you received any of them? Not yet. All right. Well, in the meantime, whilst I have received a few questions, and I'm going to be getting our team to send us through some of those questions themselves. I think that the one point that has been very well clarified has been around the issue of the prioritization. We do prioritize in testing. We do prioritize because we must just remember, even though we talk provinces, it's a national campaign. So all the work, all the resources have to be targeted to the area where nationally we believe that's where the focus has to be. So that's the attention that is going to the Western Cape. Not only that, we are going to be visiting Western Cape next week. Personally, I will do so, and then later the President will also be visiting, but we will work with them. You will also notice that we have given attention to these provinces where there were problems at each time to deal with the issues. So the question that has been raised with me, can the department indicate what is the timing of the determination of hotspots entail? Will it be every 2 weeks, as mentioned in the minister's presentation to the NCCC, or can it be done within a day? I'm not sure what the question is saying, but we will be looking at a 2-weekly cycle during which we will then be indicating and doing the assessment of where the what the level of transmission is. It can be done within a day, it can be done within a week. If you look at how the cycle of the COVID-19 tends to be happening, for these few weeks that we understand that you need a period of about 2 weeks to allow symptoms to set up. You also need someone to be on treatment or on isolation for about 2 weeks, and therefore it is helpful to try and synchronize it that way. So we have announced the list right now, but at the same time we'll do evaluation. We monitor every day what happens, but then we will actually look at the situation every 2 weeks and determine whether there is a change of action, change of plan that is needed. Then the second question is, how will the rationing of tests hamper the government's hotspot strategy? And as far as we would be concerned, the first issue is that why we had Dr. Tumi indicating where they are, it is really because our approach is to look for solutions so that you get rid of these backlogs. So as far as we're concerned, if we can make it, we'll want to eliminate the backlog so it doesn't become a big issue. At the end of the day, if you look at the data that has been released by Professor Abdul Karim, you'll notice that you can work out what the challenges are and what the trends are based on what tests that have been done already, so that doesn't hamper. So what we need to do is to go into Western Cape, eliminate the backlog as far as possible, so that we keep them ahead of the curve. We are able to find people as they turn positive, because the highest rate of positivity is in the Western Cape. The other provinces, there's another strategy we will be using to make sure that they don't get left behind, but that's an issue which is technical within the laboratory services. So the issue, therefore, is about us ensuring that of all the people who are positive cases in the Western Cape, we can immediately implement isolation, we can immediately implement quarantine of the contacts, because we actually think that with an aggressive approach, you can still temper the rate of growth in the Western Cape, and that has to be accepted by the community, that it is the community change of behavior that's going to make a huge impact. The test can actually help us to reduce the rate of spread, but it is limited unless the community also takes over that part. So the major issue is not so much the test. We can even find a way of managing the outbreak on clinical basis, even if there might be constraints on the test. So as far as we would be concerned, that is possible. We can manage that, but more important for us is the change of behavior, which is what we're advocating for. Then another question, they didn't say who asked these questions, but this one has been said to come from Adrian Passon, News 24. Can Minister clarify the three differential areas, low hotspot and out of control? When will these areas be announced, and will these areas, including out of control, still move to level 3 on Monday? Well, these areas that are differentiated is public knowledge. We can always at any one time make that list available. Mainly there are two groups that have been published. One is low transmission areas. That has been part of our regular presentation. The other one would be the hotspots that also has been part of our presentation. The President did announce them. So those are the key areas. Now, the one that we say is out of control, we haven't got to that point yet. What we are doing is that as we send teams to and subdivide the metros, the districts which are hotspots, we are actually setting up mechanisms to be able to increase and intensify our interventions in identifying the positive cases and in ensuring that they are isolated, and we actually temper this, the spread of the infection. So that is what we are busy with. We will therefore work out with time if our teams are effective or not, and then we can say this one is out of control. Therefore, certain things need to be taken. But the teams that are in there will use the same toolbox. And I want to leave it because I think Professor Abdul Karim might also want to comment on that.
I have a question here, Minister.
Sorry,
I have a question. Yeah.
Okay, let me just do this.
Sure.
No, I think you should proceed. If you could take the next question. I've got a few other questions here. We might also ask other members who've got questions to come on board.
Sure, Minister. I've received a question from a Dr. Patel saying that in Tshwane, one of the private schools has purchased tunnels which they are planning to install for the students to enter school. And the question was, is this a problem for the children to go through these tunnels? If I can ask Professor Mkhize to please respond to this, because she has led the initiative in the Ministerial Advisory Committee to collect the evidence on this matter. Professor Mkhize.
Thank you very much, Professor Karim, and good evening, Minister. The answer to the question is very simply that disinfectants and chemicals are dangerous for humans. Children are particularly vulnerable, particularly at the respiratory tract, the eyes, and the skin, as we've already been mentioned and you've heard. So there is no need for a disinfection tunnel, and there's no need for spraying children with any chemical in any part of the world. So I hope that answers your question.
Thank you very much, Professor Mkhize.
Are we done with that?
Yeah, we're done.
Yes, there's one. I'm going to send one to you once we're dealing with this, so that you can take the next question. The next question I'd like to deal with relates to.
I've got the question.
You've got the question?
Yeah.
Or please take that question.
So this is a question from Sidwell Guduka from the Mail newspaper. And the question is, does the person who has already recovered from COVID have the same level of transmission, potency, and duration when reinfected as the person who catches it for the first time? So Sidwell, let me tell you what the current evidence is based on research that we have to date. We now have an understanding that most people, it's just a small fraction who do not do this, most people develop antibodies against this virus. Those antibodies are potent in that they do kill the virus. At this stage, we do not know how long those antibodies last, and we do not know whether they are effective in preventing reinfection. Those two questions remain unanswered. What is emerging, and this is data we have at a preliminary level, mainly from China at this stage, because they are seeing the second wave, is that patients who have had COVID, that's the illness, the first time, when they've recovered, even if they do become reinfected, they do not get COVID again. So you don't get the disease twice, but we do not know if you get the infection twice. So to answer your question in short, it is an open question because we do not have definitive data. Remember, this virus has only been with us for about 6 months. And at this stage, it looks like the immune response is present and produces antibodies, but it's not known whether it prevents reinfection.
Thank you very much. Could I ask if Dr. Leslie Bamford could come forth and just quickly comment about the return to school and all the work they've done with the Department of Education, and also in that context, invite Dr. Achari and Professor Velapi to also make some comments on the same issue around the children going to school and the issue of COVID and children.
So good evening, Minister, and good evening to everyone else. In terms of, in the past weeks, we have been working very closely with our colleagues in the Department of Basic Education in preparation for schools opening. Basic education, every province has a plan for opening of schools, and schools will only open once they are certain that they are ready to receive learners. From the health side, our main role will be assisting schools with screening and also making sure that any children who do display symptoms, children who screen positive, are managed correctly, that if they require testing, they are tested and that they receive the management that they require. We are also working closely with the Department of Education and schools in making sure that schools are as safe as possible so that all the preventive measures are put in place. As people are aware, some schools will open on Monday. Other schools are probably not yet ready and will probably open during the course of next week or even the following week.
Thank you very much. Could you ask?
Sorry? I've got the next one.
Can you just check if Professor Velapi or Professor Achari, anyone of you would like to make any further comments on the COVID and the children?
I think just to mention that, so in our review of the literature, what we find is that children overall have a very mild disease and they really have a lower incidence of infection. We also find that children are much less likely to transmit infection both to other children but to also adults. And for those reasons, I think we strongly felt that these were the reasons why children should really start going back to school in a more structured way and making sure that this is in a way that allows children to return to a normality and a normal to education. So I think that the idea is to make sure that this happens in a way that presents an opportunity to mitigate the risks associated with the return to school.
Thank you very much. Maybe Professor Velapi, could you just share on the issue of babies born of COVID-positive mothers?
Good evening, Minister, and good evening, members of the Ministerial Advisory Council and the viewers. Yes, I think for some time there's been a debate on whether the mothers can pass the infection to their babies. And I think some evidence is coming out more and more that yes, that is the case, that the mothers can pass the infection to their babies. And I think the next question is when can they pass that infection to their babies? So it can happen while the baby is inside the womb, or it can happen after delivery. I think the studies that are coming up now in terms of case reports are showing up that it can happen in utero and post-delivery. I think recently there's been a study that came from UK where they look at over 80,000 mothers who delivered in their hospitals. And they found that for every 1,000 pregnant mothers, 5 had a COVID disease. And of those, only 12 babies had the COVID infection. So which means although the infection can be passed on to babies, that risk is very low. So I think we still need to watch that space very, very closely. But currently, the recommendation is that if the baby is well and the mother is well, even though the mother is COVID positive, the importance of breastfeeding is very critical for survival of babies, that the mother would continue to be with the baby in terms of breastfeeding, but the mother must have a mask and must observe hand hygiene while nursing the baby. Yes, the mothers can pass infection to their babies, but that risk currently seems to be very, very low. So, but we need to monitor very closely as time goes on with this infection. Thank you, Minister.
Thank you very much. I should have also asked you to comment on the Kawasaki. There's been some issues around there. Is there anything you'd like to raise now? Maybe if you want to come back a bit later.
Yes, and also recently there's been a number of reports from UK and US where patients present with what look like a Kawasaki, which usually is an infection that affects the mucosa with conjunctivitis or redness of the eyes, the skin with rash, and the palms and the soles being also red, and also they can also have the heart being affected. So this has been seen in a number of children, but it doesn't seem to be occurring at the time that they have infection. It seems to be occurring 2 to 4 weeks after the infection, suggesting more of an immune response to the infection. So which has been seen with other viruses. So this is one concerning because they come in very sick, and sometimes when they present with more like abdominal signs, like severe abdominal pain. They might have diarrhea and vomiting, unlike the classical presentation of cough and fever that is seen earlier on with the infection. So this is one complication that is very worrying that we need to be watching for. Thank you, Minister.
Thank you very much, Professor Belapi. There is a question which was directed to me about the modeling and the delaying of results.
I've got it.
You've got that? Yes, thank you.
So I've got 2 questions here.
As well.
I've got 2 questions here, Minister. The first is from Nabila Sheikh from ETV News. She's asking, can you please explain how we are getting our recovery figures? No follow-up tests are done on those who test positive and self-isolate. They are only tested once. They are asked to stop isolating after 14 days, but are not tested again. In this case, what method is being used to get recovery figures? I'd like to ask Professor Mark Mendelsohn to address this question. He has been developing the criteria for recovery and for case definition. Professor Mendelsohn. He may not be on. Okay, I'll answer it then. On the way in which the initial criteria were developed. Originally, when the epidemic started in China and moved to Italy, the criteria for diagnosing a patient was to have a positive result. And the criteria for recovery was to have 2 separate negative results. Shortly thereafter, the World Health Organization changed those criteria because of the worldwide shortage of tests. And as we gained experience, we realized that actually patients after 14 days are generally no longer infectious. If a patient remains without symptoms after the 14 days, then that person is considered to be recovered. That is the standard definition that is now used the world over. There is no need to have a negative test in order to define recovery. This is a separate issue with regards to patients who have been admitted to hospital and who have been cared for through ICUs and through ventilators. In those patients, we take the date of discharge. In other words, that's the date on which the patient is considered to be stable. And 14 days after that, the patient is regarded as recovered. And this is based now on our global experience of what defines whether a patient has recovered or not. So it's a standard definition and does not require testing any longer. The next question I have is from Chris van Vieren from International News Network. He asks, private test results arrive in 2 days and the government hospitals take up to 2 weeks. How much does this affect the modeling and planning for the future? I'd like to ask Professor Meyerath to respond to this question. She is one of the leaders in the modeling group, and she's a member of the Ministerial Advisory Committee. Professor Meyerath.
Good evening. Thanks a lot. The model itself takes into account detected cases, so people who have had a test and whose COVID-19 status is known. But we project cases, hospitalizations, deaths, etc., regardless of whether or not people know their status. So we keep tally of the total number of tested people, but it does not actually affect model projections altogether. The only way we think it would affect essentially incidence and thus our projections is if we continue to not be able to, in the surge, not be able to basically zero sort patients into COVID and non-COVID wards in the hospital setting, which could lead to increased nosocomial infections and thus higher incidence, probably quite marginally, but that would be a factor to take into account. So we are watching the turnover times just like everyone else at this time.
Thanks very much, Professor Meyerath. If I can just also add that when we look at the current epidemic situation, we have a multitude of different approaches to producing estimates of what the current situation is in terms of detected cases and undetected cases. And one of the ways in which we can do that is through a back calculation method based on deaths. Death reporting generally is more accurate. And in order to estimate what your cases are 7 to 14 days prior, you can do a back extrapolation that has been shown in many settings to provide quite accurate estimates. So we can use a range of different methods. And there are methods by which we can also adjust for a slowdown or a variation in the amount of testing that's done when we are doing our estimations. So I think that answers that question. I'll leave it to you, Minister. I have no further questions that have come in to me yet.
Okay, thank you. I've got a question which is quite wide, and so I've asked that, three people must take have a go at it. The question, I've asked Dr. Kerrigan to have a comment, Dr. Kemi Chetty to have a comment, and Dr. Tumi to have a comment. The one talks about the shelf life for specimen taken. The other aspect talks about unintended consequences of samples. That will come to Professor Abdul Karim. I'm going to send it. And then the other one will go to, the other aspect will go to Dr. Tumi and Dr. Kemicheti, Dr. Tumi, and Dr. Kerrigan would comment on it, and then also Professor Abdul Karim would like to comment. I'm not sure if they've received it. Could I just check, Dr. Kemicheti, can you see the question? The person didn't say who their names are. In future, we should request people to put their names so we know who we're responding to. But Dr. Kemicheti, can you pick up the question?
Thank you, Minister. The first question about shelf life, is that the one you want me to answer?
Yes, and any other that you fancy in the whole list.
So, Minister, with regard to the shelf life of the specimens, our expert committee of virologists, we're concerned about specimens that were older than 5 days, and we're recommending that we should look at whether those specimens should be rejected. But there have been also other studies that have been done which have stated that if the specimen is put into the refrigerator, it can last a lot longer. The approach that we take in following discussions with yourself is, rather than having a general sense of saying that specimens over a certain number of days would not be worth testing, we're saying let's look at the specimens and check whether there is any degradation, and we determine it from that. We've also are looking at creating a call center so that we can discuss with the patients directly if there is problems with the degradation of the specimens. So we're not going to be taking a uniform approach at this time. All of our specimens are put into refrigeration, and we'll be looking at each one individually. So, Minister, I'm going to need to put my reading glasses on to see the other questions. So perhaps if someone else can take the next one.
Let's get the next one. Dr. Kerrigan, do you want to comment?
Yes, thanks, Minister. The question around the unintended consequences of delays in specimens refers to the downstream processes where specimen collection is taken in order to understand if a person has COVID disease, and thereafter, if the diagnosis is made, then certain actions need to happen. So if that diagnosis is delayed, then some of those actions may not be able to happen. So, for example, if a patient is admitted to a hospital with pneumonia and it's suspected that they have COVID disease, a test would be taken, and if there is a delay in the meantime while waiting for the test, the patient will be put in a patient under investigation ward where the healthcare workers have appropriate post-exposure personal protective equipment, PPE, and are adequately protected. And if there is a delay in the results, then it means it takes longer for the patient to be moved into a ward that is dedicated for COVID, or a ward for non-COVID patients. So that is one of the downstream implications that has more serious consequences in terms of the utilization of PPE. With regard to individuals who are tested as part of the community screening and testing program, those persons are tested because they meet certain criteria around symptoms, so they have fever or cough or symptoms of respiratory tract infection, they are advised to self-isolate after taking the test, because they may have COVID and one would not want them to transmit COVID on while they're waiting for the test. If the test is delayed, then it means that they need to stay in isolation until the result is available. However, the consequences of this delay are less significant, because if the individual has COVID, then it's a good thing that they're isolated, and the length of time they would have to be isolated for 14 days anyway. And if they don't have COVID, they most likely have an upper respiratory tract infection or a cold or influenza. And if they're isolated, it means they won't be able to pass that infection on anyway. So the consequences of that are less serious. But what is clear to us is that it is important, if we are going to adopt a targeted testing strategy, that we identify very clearly which persons are in need of testing over and above certain others, and also that we develop in the field ways of responding and containing COVID as effectively, even though we may not have access to tests at certain times of the outbreak. So that is what we're working on. I hope that answers the question. Over, Minister.
We have Dr. Tumi. There's a question about the compatibility with NHLS.
Yes, thank you, Minister. For some reason, I think my video is not working. But just briefly, yes, these tests are compatible with the NHLS as well as the private lab machinery. So you would have seen on our list, we've got products such as the Abbott test, the BD, the Roche, as well as Cepheid. So they are compatible.
Thank you very much. Would you like to come in?
Minister, could I come in on also the compatibility issues? Just to say that there's two different platforms that we have. One's called an open platform, where there's a number of different kits that could be used on that platform. And what we do is we validate those test kits first in order to know whether it can work on the open platforms. And then some of the other kits that Tumi has just mentioned are for the closed platforms, where only that test kit would work on that machine. Thanks. Over, Minister.
Thank you. Would you like to come in?
No, I was actually going to ask Dr. Myatt if she wants to comment on the question 3. Does the number of tests performed as reported on TV daily refer to specimen samples taken or to the results of tests? Dr. Myatt?
So this is a combination of both. There are results and there are specimens taken, and we keep them separate. And when we report, we only report on the positive cases, but we have the total number of tests taken as well. I think that's important for us from an epidemiological point of view to analyze how many tests are taken and how many positive tests are as a result of those tests taken. So it is a combination of both.
Thank you very much, Maya. So the reporting is based on the tests that were done on that day. The samples may have been taken a few days in the past, but the date of reporting is the date of this test.
That is correct. There are various permutations in terms of sample collection date, in terms of date of reporting of test, and all of those are factored into the reporting requirements. But we report on the date of the sample collected.
I've got no further questions.
Thank you very much. Let me take a couple of the questions that had come in a bit earlier. The first question talks about whether this comes from Evelyn Morris, Caxton, Devon, with identification of hotspots, such as those in KZN being made. Will the KZN department now be compelled to announce regional and district breakdown of cases, deaths, and recoveries as well as numbers of tests done. We will check what the provincial department is releasing, but a lot of this information is just simple information to release. And so I'm aware that they keep a lot of detailed information of this nature. So we will discuss with them to see what is it how they've been releasing them, whether there's any problem as it were. But from where we sit, every province will be free to announce what the figures are per district and what the situation is. But when it comes to identification of the hotspots, that gets done from national office, and most of the figures will also be released from national office. But only looking at the breakdown into sub-districts, into municipalities, those would be left to the provincial department to do. So we'll just liaise with them just to make sure that we understand if there's been a gap in the report. The second question was asked by okay, didn't say who the person was, but the question is, President Donald Trump announced that the US will terminate its WHO membership. What impact will this have on the global fight against COVID-19? Well, it's a bit difficult to know what impact it will have, except just to comment that it was unfortunate that we get that turn of events. Certainly when you're faced with such a serious pandemic, we would love to make sure that all the nations in the world are particularly focused and united in the fight against COVID-19. And we hope that whatever the issues are, they may be resolved in such a way that we can all have a focus on the one common enemy, and that is COVID-19. And so we hope that over the process, the different players will be able to find each other to resolve whatever issues there were. But as far as we're concerned, we do continue to work with the WHO, and we believe that they have done a reasonably good job in the guidance of how to approach this issue of COVID-19. And so we hope really that nothing detracts us as the global community from dealing with the COVID-19 pandemic. The last question comes from Tamara Khan. It basically is a question around the issues of from Tamara Khan from Business Day. Can you elaborate on the process government will use to determine whether to return a hotspot area to alert level 4 or 5 or not? The trigger point for imposing these restrictions will be, and whether this would be accompanied by any adjustment of level 4 or 5 regulations to accommodate people's need to earn a living. Well, a number of issues we have put in the Gazette, some of the issues for consideration. We have said, for example, that any geographical area which has recorded more than five or more positive cases per 100,000 should be labeled as a hotspot. That this is informed by weekly rate of change in a percent, excuse me, in a percent active positive cases per 100,000. That means that we take an average per week and then make a calculation. And this is opposed to whether we just take one day's numbers and make a determination. But if you look at that figure, you can then decide on which particular week you're looking at, and then determine the particular district. We have indicated a number of issues that have to be taken into account as well. Other issues will relate to the readiness of the health services to be able to deal with the patient load that is coming through. How many general beds do we have, and how many ICU beds do we have, and what about the human resources, if we've got enough human resources, and what about the relative system of health in relation to various other comorbidities and challenges that are being faced at that point. So there will be those are some of the considerations that we take into account as we deal with the determination. Now, we have also said that when it comes to the hotspots, our teams are going to assess what are the additional risk factors that are associated with a particular area. Is there a problem in the movement of people? Are there clusters, cluster outbreaks that we're identifying? Is there social conduct of the people in the area? Are there particular trends of movement of people or behavioral issues that are a factor? In which case, we'll have to put those in a package and say, these particular activities have been identified as those that will need to be restricted in order to be able to reduce the spread of the infection. The level of restrictions is going to depend on what restrictions are necessary to achieve the outcome that we're looking for. We will not upfront give a list of restrictions. We will go case by case, we'll go area by area, we'll go by progress. What is it that's making it difficult for us to be able to get this, this impact that we'd like to see? If in that situation, for example, the challenge might be that we've got limitation in terms of isolation beds, we'll have to address it like that. If we think that there are issues that relate to activities in school, in a mine, or in a shop, or in a factory that are a factor in this case, we need to deal with it like that. If it means the issues have got to do with the movement of people coming from different parts of the province that are a factor, we'll also take all of those issues into account. So we wouldn't have any predetermined list of things that will be done, but we will actually take each one on a case-by-case basis. And when we do so, we will actually focus on the restrictions. If it means that we have to make sure that the place there's no movement whatsoever, we'll have to deal with it like that. The question of what will be allowed, what is not allowed, will also be determined on that basis. So we wouldn't be able to say, you'll be allowed to do this, you won't be allowed to do this, until we are in that particular spot that we will have to look at. There has been a number of examples that we've looked at of restrictions. The one that has been quoted often is the one of Wuhan. It taught us a number of things. Although people were free to stay in their own homes, there was certain rationalization of how often you go to the shops, who goes to the shop at which time. If you looked at what happened in Korea, even just the sale of masks, you go by a particular day to collect masks based on your birthday and so on. Now, when we have to deal with the senior citizens, where you are looking at protection of senior citizens, you might be able to determine which days the senior citizens should be going to certain activities, collection of their grants, and going to the shops, and so on. So all of those things are issues that would be arising out of a particular area. So I wouldn't, we wouldn't just issue a blanket list of restrictions. And when that happens, they will be tailor-made to the particular area, so that the net effect of the restriction must be to lower the infection rate. And that is what our teams will be able to recommend to us. I think that for me makes the last question. Please, if the professor can come in. And after Professor, I'm going to ask the Deputy Minister to also make some comments and respond to some of the issues where we would have liked to respond and make comments. Then we'll bring it to a close. Professor Tulkani.
Thank you, Minister. Just to add to the question from Business Day, I think we in the Ministerial Advisory Committee have a group working on this very issue of trying to develop more sophisticated measures to determine what might best predict when we are losing the battle in terms of flattening the curve. In other words, at what point do we anticipate that the number of cases will outstrip our health service capacity? And there are ways in which we can do this based on the epidemic trajectory. And that has to be done, at this point, we're focusing on the district level, but even further down. So I think you're going to see this as something that's in evolution, and we hope that we can get better and better estimates over time. And it's also dependent on the quality of the data we can get. I just wanted to make one last comment, if I might, Minister, on the issue of the World Health Organization. The Ministerial Advisory Committee specifically discussed the issue of the WHO, and we have felt that the WHO has been invaluable to our efforts. We routinely, almost, I cannot think of a single meeting where we have had a discussion that does not include the guidance of the World Health Organization and the wisdom of the World Health Organization. So to us, in tackling this epidemic in South Africa, we are heavily dependent on the work of the World Health Organization. So we want to wish them well and wrote to the Director General to reinforce our dependence and our gratitude for their contribution. And then finally, just to say that the public should be absolutely confident that the Ministerial Advisory Committee is just totally devoted to dealing with this epidemic, and we are giving it our full effort in order to ensure that we produce the best available evidence to define the best available way forward. Thank you, Minister.
Thank you very much. Firstly, my apologies. I just missed the fact that the Deputy Minister has a family bereavement, and we convey our condolences to the Deputy Minister and the family. So he will not be able to make any further comments at this point. But also, let me reiterate and echo the words of Professor Karim. Everything that we do, every step that we take, before we do so, we all go back to check what are the WHO guidelines on that particular matter. We have found them to be the most useful reference point as we respond to the issue of COVID-19. And then we also say that on a continuous basis, we are working with WHO at the public and the private levels, where we seek advice and where we share ideas and where we get continuous technical support. We would certainly want to confirm our full confidence in the WHO as a body, a multilateral platform for dealing with health concerns for the whole global community. And of course, we have also full confidence in Dr. Tedros Ghebreyesus as the Director General of the WHO. Having said so, we also need to indicate as well, fellow South Africans, that the challenge of COVID-19 remains with us, that the situation is now more serious than when we first reported the first case. And therefore, it becomes very important for all of us to realize that we have to take personal responsibility. The reason why we are opening up and relaxing some of the restrictions, it's not because we are over the challenge and the risk. It is because we have to balance other requirements for society. And therefore, it's important for us to single-mindedly focus on the fight against COVID-19. It's also very important for all the leaders, and I want to commend various leaders, including those of political parties, for lifting the issue of COVID-19 above areas where we should be politicking, and this has really made it much more, easier to face the huge burden of fighting COVID-19. I want to again pay tribute to all our health workers, our fighters and our soldiers in the forefront in this battle against COVID-19. We do want them to know that we appreciate their effort, their dedication, their commitment, and would like to always wish them to be stronger and to continue their commitment in the fight against COVID-19. And we want to indicate as well our appreciation to the rest of South African society who are giving us as much support as necessary, who are interested excuse me, in what is happening, would love to encourage everyone to remember it is about change of behavior. A new culture has to be born where to avoid infection, we must protect those senior citizens and those who have got comorbidities. We must make sure that we exercise the cough etiquette, use our mask when we get out of our homes, and make sure that we have hand sanitizers, wash our hands frequently, and keep a distance. Those are the key issues of how we'll be able to deal with the COVID-19. There are debates, there are controversies out there, but let's do all our discussion on the basis that we're trying to do our best and try to improve on the solutions that have been put on the table. Let us also reach out to one another and be, each other's guardian, and let's reach out to one another. And where we think we can contribute, let's do so rather than having destructive debates or criticism. I think it's more important to be able to help each other, support each other, and make sure that our campaign is stronger. At this point, therefore, I'd like to say thank you to the Ministerial Advisory Committee for all the work that they've done, to the acting DG and all the senior managers at the Department of Health and in various provinces, together with my colleagues, Deputy Minister and the MECs. We also want to thank the members of the media for your continued interest and the staff that has put together this whole organization. We want to say thank you to all of you. We know it has taken much longer, but we hope that you have answered your questions. We also hope that in the process, we will be able to help you to focus on how to change our behavior. And at this point, therefore, I'd like to bring this meeting to a close, and we want to thank all of you, and good night. The meeting is closed.
All right, so that was the Health Minister, Dr. Zweli Mkhize, along with the Ministerial Advisory Committee and other senior officials with the latest briefing on COVID-19 health interventions ahead of the move to alert level 3, of course, of the lockdown on the 1st of June. The Minister says that the lockdown has achieved what it was intended to do, and that was to flatten the infection curve. And that was echoed by Professor Abdul Karim, who said that in the 3 weeks before the lockdown, the epidemic was doubling every 2 days, and if it had continued along that path, well, we would have had a situation where those tests would have seen the same scenario as the United Kingdom playing out. So the lockdown has worked. He says